Alrighty, well, good afternoon and welcome everybody. Thank you for joining us today. My name is Andrew Doffney. I'm the Instruction and Outreach Librarian at the New Jersey State Library. And it is my pleasure to present our speaker for today in honor of National Women's Health Awareness Month, which is May. It's Dr. Joyce Varughese from Capital Health Surgical Group. Dr. Varughese is a board-certified, fellowship-trained gynecologic oncology surgeon who specializes in performing traditional and minimally invasive procedures using the Da Vinci robotic surgery system. Dr. Varughese has completed her fellowship training in gynecologic oncology and residency in obstetrics and gynecology. She's serving as administrative chief resident at Yale University. She received her medical degree at Albert Einstein College of Medicine in the Bronx, New York, and her undergraduate degree, magna cum laude, from Harvard University. So welcome so much, Dr. Varughese. Thank you so much for speaking with our audience today.
Thanks for having me. I'm happy to be here. So I'm going to share my screen.
I just have a few
Go
I just
ahead,
want to, just a few housekeeping items to go over. If you have any questions, please submit them using the Q&A or the chat feature in Zoom. We'll be happy to address them at the end of her presentation. If you do have time, we ask that you please complete the survey at the end of the webinar. We always appreciate hearing your feedback. And if you want some more information on gynecologic cancers, Dr. Varughese has provided me with this resource here, so please check it out at your leisure, and I will post it in the chat once we get underway. And the last thing to go over, I just want to do a brief overview of the Zoom dashboard for anybody who might be unfamiliar. This is what your dashboard should look like if you're using a PC or a Mac. If you're using a mobile device, the dashboard may look a little bit different, but all of the features will still be there. In the bottom left-hand corner, you will see your audio settings. This is where you can check to see if you are using an external listening device like earbuds or a headset. You can make sure that it's properly connected there and adjust your settings. At any point during the presentation today, if you have any issues, there is a raise hand button here in the middle. You can click on that. That'll alert me, and I will send you a message in Zoom and hopefully be able to resolve any problems that you are having. And lastly, as I mentioned, if you have questions, you can either use the Q&A or the chat buttons, and we'll be happy to address them at the end of the presentation. So that is everything that I have for you. So it's my pleasure to turn it over to Dr. Varughese.
Thank you. And that link that Andrew is going to post in the chat, SGO stands for the Society of Gynecologic Oncology. So that's our national professional society, where you will find on their website all things related to prevention and treatment of gynecologic cancers. So today, in honor of National Women's Health Awareness Month, I want to talk about cancers in women, and really not about the treatment or the diagnosis, but how can we prevent them or do early detection. So as Andrew mentioned, I'm a gynecologic oncologist, and I'm the medical director of GYN oncology at the Capital Health Cancer Center. So I've noted disclosures, and so really my aim for this talk is for you to come away with knowing some of the signs and symptoms of gynecologic cancers that should prompt further evaluation, and to identify some modifiable risk factors for GYN cancers and other interventions that can potentially reduce your risk or your loved one's risk of gynecologic cancers. So what are the gynecologic cancers? So there are 5 main ones. So the most commonly diagnosed is uterine or endometrial, and the endometrium is just the lining of the uterus. There's cervical cancer, which is basically the very bottommost portion of the uterus, vaginal cancer, vulvar cancer, and ovarian. And really, we lump fallopian tube and ovarian cancer kind of together. So today, we're really going to talk about the 3 most common GYN cancers, so uterine cancer, ovarian cancer, and cervical cancer. So why do we care? So cancer is the second leading cause of death among U.S. women. Every few years the slide gets updated, and this percentage here, you'll see that heart disease is still the #1 killer of women, with about accounting for about 22% of deaths. But you see that cancer is not that far behind, and they anticipate that in the next several years, cancer will actually overtake heart disease as the #1 killer of women in the United States. So in terms of uterine cancer, so just in terms of the anatomy, here's the uterus. The cervix is technically just the lower portion of the uterus, but for GYN cancer issues, we actually separate them out because they kind of behave a little bit differently and they're treated a little bit differently, and they have different risk factors too. So the other term you might hear for the uterus is the womb, because this is actually, this cavity here is where a baby develops and grows, and the placenta attaches here to this lining. This is where patients could sometimes get polyps. If somebody has an intrauterine device, this is where that would sit. So, so this is the organ of interest that we're going to talk about first. So uterine cancer is actually the fourth most commonly diagnosed cancer among women in the United States, over 60,000 new cases in the U.S., but it is the sixth most deadly cancer, accounting for about 12,000 deaths annually. The risk of getting uterine cancer is only about 3%. So basically, out of every 100 women in the U.S., 3 of those will at some point in their lifetime be diagnosed with uterine cancer. The average age at diagnosis is 62. And most women are postmenopausal, meaning that they have gone over a year without a period when they are diagnosed. However, a quarter of women, so 25% of women, are premenopausal at the time of diagnosis of uterine cancer. And believe it or not, 5 to 10% of patients that we see are less than 40 years old when they're diagnosed with uterine cancer. So what are some of the risk factors? So there is a cancer syndrome called Lynch syndrome. So some of you may have heard of some of the other familial cancer syndromes, such as BRCA or BRCA, that is responsible for increasing people's risks of breast and ovarian cancer. Well, Lynch syndrome increases one's risk of colon cancer, but also of uterine cancer, small bowel cancers, ovarian cancer. The relative risk is about 6 to 10. So basically, there's a 6 to 10-fold increased risk if somebody has Lynch syndrome that they may get uterine cancer versus somebody who does not have Lynch syndrome. And again, these are specific genes that are inherited from your mother or your father that increase your risk of developing certain cancers. So that's not really something that's modifiable. But look at this. Somebody who's obese or 50 pounds or more over IBW is for ideal body weight. So if you're 50 pounds or more over your ideal body weight, you also have a 10-fold increased risk of developing uterine cancer. So it's as though you were born with a gene that increased your risk of uterine cancer. But this, though, is modifiable. People used to, we no longer do this because we know about this ovarian cancer risk. If you use only estrogen, but you have a uterus, you're really supposed to use estrogen and progesterone, because if you only use estrogen for hot flashes, night sweats, you're going to increase your risk also of uterine cancer. The use of tamoxifen, which is a medication that is often used and prescribed for certain women with breast cancer, that also increases one's risk of uterine cancer. Even if somebody's 30 pounds over their ideal body weight, that increases their risk of uterine cancer. Other things are diabetes, not having any children. The older you get, the more likely you are to develop uterine cancer, and even having hypertension, completely separate. Even if you're normal weight, not obese, but have high blood pressure, that increases your risk of uterine cancer. Some protective factors are having had pregnancies in the past, if you're over the age of 15 at your first period, or if you've used birth control pills or any sort of progesterone-containing birth control. So the Depo shot, the Implanon implants, the intrauterine devices like Mirena or Kylena or Liletta, the ones that have hormones in them, those all decrease your risk of developing uterine cancer. So how do women with uterine cancer present? Most women will have some kind of abnormal bleeding. Because most women are diagnosed after menopause, the most common symptom we see is that women bleed after menopause. So they come in and they're like, I haven't bled in 5 years. Why am I having spotting or bleeding? And it doesn't always have to be like a full-on period. It can be even sometimes just like pinkish discharge or brownish discharge that's new, because that may indicate some old blood. Late menopause. So if somebody's 59 years old and they're like, I'm still having periods, that may indicate that there's something going on, or it could just be that they are somebody who's going to undergo menopause at a later age. However, it is something that should just be evaluated. In a younger woman, if somebody just all of a sudden starts having heavier periods with no real cause or reason identified, if somebody starts having bleeding in between periods or shorter cycles, those are things that just need to be evaluated. There are a lot more common things than cancer that can cause those, such as fibroids or polyps, which are all benign conditions, but it is something that should just be evaluated. Sometimes patients will present with pelvic or abdominal pain. Occasionally, patients will have vaginal discharge. And some signs of uterine cancer can be a pelvic mass. On an ultrasound, sometimes we can see that the lining of the uterus or that endometrium is a little bit thickened, but we don't always need to see that. So the role of obesity. So obesity is a medical condition and is defined by body mass index. So basically you take your weight in kilograms and you divide it by your height in meters squared. And so normal body mass index is less than 25. Somebody who's overweight has a body mass index of 25 to 30, and if it's over 30, it's considered obese. 65% of the U.S. population is overweight or obese, and being overweight or obese accounts for 20% of cancer deaths among U.S. women. I just want that to sink in, that being overweight or obese accounts for 20% of cancer deaths in U.S. women. And why is that? So this is just actually a picture of the surgical robot that we use for endometrial cancer surgeries. There's a patient underneath all this drapery, but this is the surgical robot, and I or another surgeon sits at a console within the same room to help direct those arms and to do the surgery. So 40% of all endometrial cancers can be attributed to obesity. And the reason for that is, I don't know if any of you liked organic chemistry or took organic chemistry. It was not my favorite subject, but basically testosterone, which men and women have, gets converted to an estrogen in the fatty tissue through a specific enzyme called aromatase. Now, how I explain this to when patients come to see me is that if you look at really overweight men, it looks like they have breasts. That is not just fatty tissue. That is their testosterone getting converted to estrogen in the fatty tissue, stimulating their breasts to grow. So in women, being overweight or obese increases one's risk of breast cancer, but also of endometrial cancer or uterine cancer. We actually know there's about 10 to 12 other cancers that are increased risk because of being obese. And what it does is that this extra estrogen now leads to this imbalance between estrogen and progesterone, which are the two main hormones that act on the lining of the uterus, and you develop something called endometrial hyperplasia. Those are precancerous cells. And if that's left undiagnosed or untreated, it then progresses to cancer. Really, the obesity impacts all of our treatment decisions. It makes surgeries harder. It makes it more risky to do surgery on patients who are obese, just from an anesthesia standpoint, from a wound healing standpoint. The surgeries can be more difficult. There's increased complications. If somebody needs radiation or chemo afterwards, there's challenges in terms of optimal dosing, just given the layers of fatty tissue that need to be penetrated by the radiation x-rays, or even for chemo, how it's kind of dispersed in the body. Having more fat within the body changes actually what your optimal dose is going to be. So we briefly touched on Lynch syndrome, but I just want to come back to this because this increases one's risk significantly of endometrial cancer. And basically, it just refers to patients and their families who have a genetic mutation or a genetic defect in specific genes that help repair their DNA. It does increase one's risk of other cancers, like I mentioned, ovarian, stomach, small intestine or small bowel cancer, cancers of the urinary tract, so the kidneys or the ureters, which are tubes that go from the kidneys to the bladder, pancreatic cancer, and certain skin cancers. So how can you prevent endometrial cancer? Basically by maintaining a healthy weight through diet and exercise, meeting with a nutritionist if needed, talking with your primary care doctor if you meet criteria for certain weight loss medications or even weight loss surgeries or medical weight loss programs. knowing your family history, because if you have a family history where you're like, oh yeah, I've actually had several cousins or aunts or uncles who've had colon cancer or uterine cancer, well, you may want to talk to your doctor about that, and you might want to undergo genetic counseling and testing, because it may change your screening and your recommendations for preventing certain cancers. There is some data suggesting there's an increased risk in BRCA1 patients for certain types of uterine cancer. And so if you are found to have Lynch syndrome, the way that we prevent uterine cancer is basically we recommend that somebody have a hysterectomy once they're done having children or by their mid-40s, because we know that the risk of cancer increases after the age of 40. So basically, increased BMI or increased body mass index, so being overweight or obese, leads to this increased estrogen production in the fatty tissue. Postmenopausal bleeding, so if you go to visit your grandma and she's like, yeah, and you're talking and she mentions that she noticed some blood or on her pad or on the tens or something like that, that's always something that needs further evaluation. That does not mean that they have cancer. There's a lot of other things that cause bleeding, even in a postmenopausal woman, that are not cancer, but that needs to be ruled out. Luckily, most uterine cancers are diagnosed at stage 1 because people bleed abnormally and then they seek care. We do not have any screening tests for uterine cancer. So it's not like you can go to your doctor and ask for a uterine cancer screening test, because we don't have one. And also just know your family history, because if you think you might be eligible for genetic counseling or genetic testing, that's something to discuss with your physician. So then, shifting gears, we're going to talk about ovarian and fallopian tube cancers. So the ovaries and the fallopian tubes are, the ovaries are these like small, almost like almond-shaped and sized hormonal organs that are attached to the uterus and also attached to the fallopian tube. The role of the fallopian tube is to catch the egg when it's released by the ovary, and to transport that to the uterus if it's fertilized. So the reason we lump kind of ovarian and fallopian tube and even something called primary peritoneal cancer together is because they all appear the same under the microscope, and they behave the same way, and they are all treated the same way. So in terms of ovarian cancer, it doesn't even make the top 10 list of new cancers diagnosed among U.S. women. It's actually number 11, so it's about 22,000 cases, as opposed to, when we talk about uterine cancer, about 60,000 cases. However, it is the 5th most deadly cancer among U.S. women. It beats out uterine cancer at close to 14,000 deaths annually. So the reason for that is that 75 to 80% of women are diagnosed in advanced stage. Unlike uterine cancer, which we just talked about, where most women are diagnosed stage 1, in ovarian cancer, there really aren't that many symptoms at early stages, so most women are diagnosed at advanced stage. Again, we have no effective screening test for ovarian cancer, and 1 in 71 women will develop ovarian cancer in their lifetime. So the risk in an average risk woman is pretty low. But some of the risk factors for ovarian cancer are having a family history, so having somebody, if you were tested, had genetic testing done, and were found to have a mutation in either BRCA1 or BRCA2 or the BRCA genes, your relative risk of developing ovarian cancer is 14 to 35 over somebody who does not have that gene. Even if your genetic testing was negative, but if you had a first-degree female relative, so a mother or sister with ovarian cancer, the relative risk is 3 to 4-fold. In terms of the older you are, similar to uterine cancer, similar to most cancers, the older you are, the higher the risk of developing ovarian cancer. Infertility, not having ever been pregnant, increases your risk of developing ovarian cancer. Endometriosis, which is a very benign condition that affects a lot of young reproductive age women. It's basically where you find tissue that belongs in the lining of the uterus. When you find that outside of the uterus, most commonly on the fallopian tube or ovary, that actually increases one's risk of certain types of ovarian cancers. What is protective, where you see that the risk is less than 1 here, is if somebody's had a prior hysterectomy or had their tubes tied or tubes removed, that actually decreases their risk of ovarian cancer, and having used birth control pills in the past also decreases their risk of ovarian cancer. So in terms of presentation, how do women with ovarian cancer present? Most women do not have any symptoms in early stages. They might have some really vague symptoms, and even in advanced stages, the symptoms are often vague and very nonspecific. Excuse me 1 second, I'm just going to have my office staff quiet down for a quick second. Oh, my apologies for that. So in advanced stages and even in early stages, if there are any symptoms, they're very vague. So patients can present with abdominal pain or pelvic pain, some changes in their urinary stream or habits, so meaning they might be going to the bathroom more frequently because of pressure from a pelvic mass, or they might have they might just feel like they never completely empty their bladder because there's a mass present and they can't quite empty their bladder completely. Sometimes patients will complain of bloating, or that their belly's getting bigger, or that they've gained weight, but only around their belly. Patients can note a change in appetite, like they feel full faster, or they have a decreased appetite. So that can sometimes also lead to weight loss. And some patients will have bowel changes, so nausea, vomiting, diarrhea, constipation that they did not have previously. When we examine patients, we'll oftentimes feel a pelvic mass, or sometimes feel something called a fluid wave, which is where you kind of press on the belly and you can actually feel fluid kind of going, flowing within the belly. And this is really important in this red box. There is an average delay in diagnosis for women with ovarian cancer of 6 to 12 months after the onset of symptoms. And the reason for that is, again, a lot of these are really vague, nonspecific symptoms, and patients are oftentimes perimenopausal or postmenopausal. So they talk to their friends who are like, oh yeah, that I experienced that when I was, going through menopause, and they kind of, chalk up their symptoms to other things, or oh, maybe I ate something funny, or oh, I haven't been exercising as much, right? And then they might see their primary care doctor, who might send them to a GI doctor, who, so it's because the symptoms are so vague, and none of these are specific to like GYN. By the time they present or get a CAT scan or an ultrasound that is suggestive of ovarian cancer, it's been 6 to 12 months since they first noticed these complaints. And therefore, most women are diagnosed with advanced stage disease. So we do know that getting treatment from a GYN oncologist is an evidence-based recommendation to reduce death from ovarian cancer. So a GYN oncologist is different from a gynecologist in the sense that we do go through OB/GYN residency training, but then after that we do 3 to 4 years in specialized fellowship training specific to doing complex pelvic surgery, doing staging surgeries for GYN cancers, prescribing chemotherapy. We also do complex, like other abdominal surgeries, because many times for GYN cancer, specifically ovarian cancer, we may have to remove the appendix or remove part of the bowel. So we train to do all of that as well. So, is there anything that you can do to help prevent ovarian cancer? Because again, we don't have screening tests for this. So the vast majority of ovarian cancers are what we call sporadic. We don't really know what causes them or why certain patients get them and others don't. But 5 to 10% of ovarian cancers are actually hereditary. The vast majority of patients who have hereditary ovarian cancer actually have something called the BRCA1 gene. So patients with BRCA genes have increased risks of breast, ovarian, prostate, larynx, and pancreatic cancers. This graph just shows the risk of ovarian cancer as somebody ages. So here's age down here, and here's the risk of ovarian cancer. And you can see the red line shows BRCA1 patients, and the blue line shows BRCA2 patients. Those are just two different genetic mutations that are the most lead to the most increased risk of ovarian cancer. So for BRCA1, you can see that the line starts to increase around age 40. So their risk of ovarian cancer increases around the age of 40. In BRCA2 patients, that line does not start to increase until about age 55. So we can delay sort of doing surgery for these patients a little bit longer, only because their risk doesn't rise until they're much older. So in terms of ovarian cancer, remember that the symptoms are really nonspecific. So what we usually say is that in women who are having vague bladder or bowel symptoms that persist for more than a week or two, those are things that should just get checked out. Again, ovarian cancer is not the most common reason for those issues, but it's something to keep in the back of your mind that if everything else is kind of getting ruled out, that might be something to look into. We do not have any efficient way to screen the population, so most of these cancers are diagnosed at an advanced stage. Know your family history. So if you have any family members, like first or second degree, meaning parents, aunts, uncles, grandparents that had an ovarian cancer, that should prompt a referral to a genetic counselor, and then you can decide whether testing would be appropriate or not. And we know that women with ovarian cancer have better outcomes when they're treated by gynecologic oncologists. We used to say ovarian cancer whispers, so listen, because the symptoms are so vague and nonspecific, although now we're finding that maybe patients are actually, the symptoms may not be as vague as we thought previously. And finally, we're just going to talk about cervical cancer, and I know there was a question in the chat, and I promise I will get to that at the end. So in terms of cervical cancer, as I mentioned before, the cervix is just the bottom part of the uterus here. And so in the U.S., there were about 13,000 new cases. So compare that to 60,000 new cases of uterine cancer. It's not as common or prevalent, but about 4,000 deaths from cervical cancer. And there were about 400 new cases of cervical cancer in New Jersey in 2019. And that's really important because cervical cancer is actually 90%, 99% preventable. So really, we're talking about 400 women in New Jersey who died in 2019 who probably did not, who had preventable cancer. The mean age of diagnosis of cervical cancer is 48 to 51. And if you look at it, in 1975, the incidence, meaning how often this was getting diagnosed, was at 14.8 per 100,000 women. So out of every 100,000 women, about 15 women were getting diagnosed with cervical cancer. And about 5 women out of every 100,000 were dying of cervical cancer. Fast forward to 2011 and look at how those numbers have all dropped in half. And that's wonderful. And the reason for that is because of Pap smear screening. However, we still have a way to go in African American and Black women because their rates of cancer diagnosis and rates of dying from cervical cancer are still 50% higher than that of white women. So really, the rates of diagnosis and the rates of death from cervical cancer in Black women in the U.S. is still basically where we were for the population back in 1975. So what are some risk factors for cervical cancer? The risk factors are early age at first sexual encounter, multiple sexual partners, even if it's just one partner, but they are a high-risk sexual partner, a history of sexually transmitted infections, a history of vaginal or vulvar precancers or cancer, immunosuppression, meaning if you take medications because you had a transplant previously, those are medicines that suppress the immune system, which is the body's way of fighting off viruses and other infections. If somebody has HIV or AIDS, that's another form of immunosuppression. If somebody's on chronic steroids for sometimes people for pulmonary, for lung disease, or sometimes for certain like rheumatologic conditions, they stay on steroids, that also suppresses one's immune system. If somebody's on chemotherapy for another cancer, that suppresses your immune system. And cigarette smoking. Really, the common feature of all these is that all of these risk factors basically increase one's risk of getting something called HPV or human papillomavirus infection, or either getting it or not being able to fight it off. So what are some symptoms of cervical cancer? bleeding after intercourse, or excessive discharge or bleeding between periods. But honestly, most women won't have any symptoms from cervical cancer until it's really late stage. And so so how does cervical cancer develop, and why am I saying that it's 90 to 99% preventable? Because we know that the way that cervical cancer develops is that 99% of cervical cancers are due to something called HPV, or human papillomavirus, which is a virus just like any other virus that we get, like a cold virus. Everybody knows about coronavirus now. There's like other cold viruses like rhinovirus that people get. And so HPV is just another virus that can be acquired, and 80% of American adults have it, and it's usually acquired through sexual activity. But it's not enough to have HPV. You have to have a specific high-risk strains of HPV, and then it has to stick around, meaning that your immune system is unable to kind of clear it for whatever reason. And then that HPV infection has to progress, not just from sticking around, but actually changing your cells to precancerous cells. And then those precancerous cells have to go undetected and not treated, and then develop into cancer if you don't treat them. And really, from that initial HPV infection, that high-risk HPV infection, to the development of cancer, the average time frame is about 15 years. And so remember how I mentioned that the rates of diagnosis and death from cervical cancer have dropped by about 50%, and that's really because of Pap smears. This has actually become a model for cancer screening. These are just some pictures of Pap smears. The one on the left is a totally normal Pap smear, and the one on the right, if you see these dark cells here, those are all cancer cells clustered within a Pap smear. So how can we prevent cervical cancer? So getting age-appropriate Pap smear and HPV testing. So in order to do that, you have to visit the gynecologist or your family medicine or primary care doctor to know most women no longer need Pap smears every year, but it really depends on what your Pap smear history has been. And so that's why it's important to establish care with somebody and to sort of, and they can let you know when you would be due for Pap and HPV testing. There is a vaccine available against HPV. I really want you to think about it as a cancer prevention vaccine. You cannot get HPV from it because it doesn't contain HPV. It contains virus-like particles, not actually the virus. And it's non-infectious, meaning you can't get HPV from it, and it's non-oncogenic, meaning you can't get cervical cancer from getting the HPV vaccine. And actually, getting the vaccine actually produces higher levels of antibody than if you actually get infected naturally. And so there were a bunch of vaccines currently licensed in the US, but we're really just going to focus on the 9-valent vaccine called Gardasil 9. It's manufactured by Merck because that's the only one that really is on the market currently. It has the reason why I was called Gardasil 9 is because it includes 9 different HPV strains. There's very few contraindications, but because it has yeast in it, if somebody has an allergy to yeast, they should not get the vaccine. And really the way that we recommend it is that it is approved from the ages of 9 through 45. So we recommend routine vaccination around the ages of 11 to 12, but kids as young as 9 can start getting the routine vaccine, and then they catch up vaccine is from 12 to 15. So if they receive their first dose prior to their 15th birthday, the schedule is that they get it at time 0, and then they are due for a second dose 6 to 12 months after that first dose. So, if you have a kid that's going for their 10-year annual physical, they could get their first dose, and then when they come back in the following year for their 11-year-old annual physical, they can get that second dose and be done. Now, if somebody gets their vaccines after their 15th birthday, they now need 3 doses. If they're also immunocompromised, again, like we talked about, HIV, cancer, chronic steroid use, certain diseases, then they should have 3 doses, which are given at time 0, then 1 to 2 months later, and then 6 months after that initial dose. Ages 27 to 45 would also be a 3-dose schedule. This is something to discuss with your doctor, whether it would be appropriate for you to get the HPV vaccine. It is recommended through age 26, and it is recommended that you discuss with your doctor between the ages of 27 to 45. So there's very few people who HPV vaccine shouldn't be given to. Basically, if you've had an allergic reaction to any of the components within the vaccine, just like with other vaccines, if you're not feeling great, right? If you have like a little cold virus or something going on, you want to wait until you get better before you get a vaccine. That's not unique to HPV. Pregnant women, it's not approved in pregnant women, so we recommend that they get it after they deliver. However, if somebody is like super early pregnant and doesn't know, and they get the HPV vaccine, there's no reason to be alarmed. It hasn't been linked to any adverse pregnancy outcomes or any side effects to the developing baby, because this has happened and they have a vaccine reporting system, and there are no adverse events have been reported. And we know that it works. Within 6 years of the vaccine's use, this was just among girls, ages 14 to 19, the prevalence of the most dangerous HPV strains, the 4 strains that were included in the initial 4-strain vaccine, it dropped by 64%, the prevalence of HPV. And then in women who are a little bit older, in 20 to 24-year-olds, the prevalence of HPV dropped by 34%. But, current HPV vaccination rates are leaving many people unprotected. 4 out of 10 girls nationwide are still unvaccinated. 5 out of 10 boys are unvaccinated. In New Jersey, these numbers are a little bit old. It's a little bit better now. It's moving now with girls. About 72% have started the series, and with boys, still about 50% have started the series. And again, about 50% of girls have completed the series, and now it's about up to 40% for boys who have actually completed the series who are eligible. I will just say that in Australia, they have a very robust vaccination program for HPV, and they are actually set to eradicate cervical cancer in the country of Australia within the next 10 years, which is amazing. So what can you do to prevent cervical cancer? Recommend HPV vaccination before the onset of sexual activity, get age-appropriate cervical cancer screening for the women in your lives, and quit smoking. Cigarette smoking increases one's risk of cervical cancer because HPV, basically, what I say is that every cigarette you smoke is like your cervix smoking 100 of them. Basically, the chemicals in the cigarettes basically make it much easier for the HPV to infect the cervical cells, but not just to infect them, but to stick around and to make changes in them, to sort of change them into pre-cancer, and obviously, if not diagnosed, then to cancer. So just in summary, and then I'll take any questions, 40% of endometrial cancers are potentially preventable. Just know that any woman who has bleeding after menopause needs to have some further evaluation, even if it was just one spot, one day, and then never came back. Maintain healthy lifestyle habits and a healthy weight, and talk with your doctor about genetic counseling if your family or your personal history is suggestive of a cancer syndrome in the family. 5 to 10% of ovarian and fallopian tube cancers are potentially preventable because 5 to 10% are related to genetics. So keep ovarian cancer in your mind if you're having abdominal, pelvic, bowel, bladder symptoms that last for more than 2 weeks, and talk with your doctor about genetic counseling, again, if your history is suggestive of a cancer syndrome in the family. And finally, over 95% of cervical cancers are potentially preventable. So we recommend HPV vaccination if it's age appropriate, getting age appropriate pap smear and HPV screening, and smoking and quitting smoking. And these are the purple is the ribbon color for all GYN cancers, and these are the other GYN cancers. So I know that there was one question in the chat. I'm just going to pull that up. So what can post and perimenopausal women do to decrease their cancer risk? I'm not sure if that was related specifically to endometrial cancer. What I always say is that is maintaining a healthy lifestyle that includes diet, weight-bearing exercise, aerobic exercise, and seeing your primary care physician so that you can identify things that are early on, and also knowing your family history, and seeking out genetic counseling or genetic testing if it's appropriate. And the other thing I always say is just know your body, like you know your body best. So if you don't think something's right or if something has changed, there's no harm in seeking care, right? I think that I know because the only patients I take care of are women, is that women often put themselves on the back burner. We are often the caregivers for our families, and we take care of their appointments and all of their needs, but we often put our own needs to the side. And so just making sure that you are taking care of yourself, and if there's something that just doesn't seem right or something seems different and off, that you make sure that you seek care for that. So another question was, does HPV cause cancer in boys as well, or are they just spreaders? Oh no, it causes cancer in boys and men. So actually, there are more HPV-related cancers in men than there are in women. So HPV is responsible for many head and neck cancers, and there's actually, in the US, there's more head and neck cancers that are diagnosed that are HPV-related than there are cervical cancers. But there are other cancers too. So anal cancer is also oftentimes HPV related. Head and neck cancer, cervical cancer, vulvar cancer, vaginal cancer, penile cancers, those are all potentially HPV related. So this is why the HPV vaccination guidelines are not just for girls or women, but actually for boys and men as well.
Is genetic testing covered by insurance most of the time?
Yeah, so that's a great question. So this is why I actually I tend not to order the genetic testing myself. I refer to genetics counselors because they know all the nuances of how to get things covered and what would be covered. But for the most part now, most insurances do cover some part of genetic testing. Obviously, it depends on your insurance company, what your coverage is. But if not, many places, including Capital Health, have a cap on what your out-of-pocket expense would be for the testing. And a lot of the companies that do the testing also work have financial navigators and have financial assistance programs, because they just, we all know that this is just a really important piece of information for people's healthcare histories and to help prevent cancer. So I don't want to misspeak, but I'm pretty sure at Capital Health, for example, I think the out-of-pocket cost is capped at about $250 if your insurance doesn't cover anything. That would be if you came in, didn't have any insurance, or had no insurance covered for genetic testing, that would be the maximum you would pay, and you would likely pay less if we could get the company to kind of cut that fee down too. So if anybody is on Facebook, you can find me at Lady Dr. MD. I post a lot of articles and that are relevant to women's health issues, not specific just to cancers, just women's health in general. So hope that would be informative for you as well. On a different note, does perimenopause cause an overall temperature change in women, not just hot flashes? I'm not sure about like their basal temperature, because I don't know that that's actually really been looked at. Hot flashes are not actually, like if you check your temperature during a hot flash, it's usually actually normal. It's actually what we call a vasomotor symptom. It's actually a flushing because of the dilation of the blood vessels. So it's not like that your entire body temperature changes, although it certainly feels like it when you're undergoing a hot flash or a night sweat. Does it cause an overall temperature change? Probably not, because it doesn't actually change what we call the basal temperature. But I don't know that that's ever actually been like looked at or specifically studied. Any other questions?
I don't see any, so I think we can go ahead and end it there, Dr. Varughese. Thank you so much for speaking today.
It was my pleasure. Thank you for having me, and I hope everybody learned something.
Yes, and in our general motto of be safe, be well, hopefully everybody took away something important today. All right. Well, thank you
Great.
again, Dr. Varughese. Thank you, everybody, for attending, and hopefully we will see you at a future program.
Have a great weekend, all.